All right, great. I guess make a weird face if you can't hear me, but hopefully the sound is okay.
Yeah.
But yeah, so today I'm going to talk about early signs and symptoms of leukodystrophies. Obviously, that's a massive topic, so this will be kind of a short overview. And mostly I'll be talking about or kind of talking around a publication that we put together as part of the LCN diagnosis group, actually quite some time ago now, and hopefully kind of make some main points related to that publication. Next slide. These are my disclosures, none are relevant to today's conversation, so we can move on. So, and if you could click through just once. There we go. When we decided to do this, our diagnostic working group through the LCN and through Hunter's Hope, we wanted to make a review that really highlighted the kind of main early features and made the diagnostic journey or the early workup of leukodystrophies kind of top of mind to people who might encounter an individual first. So people like pediatricians and other clinicians who are in primary care or kind of first line. And so we chose to submit our manuscript to Pediatrics in Review, which is kind of, it's a well-liked journal that tends to have nice, palatable reviews about all sorts of pediatric topics. And so this was ultimately published in March of 2021. Next slide. And what we were really motivated by as a group, I mean, we were called the Diagnosis Working Group, so kind of clearly we were thinking about the diagnostic journey or odyssey, if people like to say. But we were really thinking about the fact that, you know, even I guess then it was a little bit earlier, but I can say even now in July of 2022, all of you are probably all too aware of the fact that the diagnostic journey or odyssey can still be quite long. Some people are waiting months to years for an accurate diagnosis, and sometimes we really struggle to even find a diagnosis. And so there's still a lot to be done here. And we were hoping that by focusing on early signs and symptoms or the clinical presentation of these disorders that are maybe collectively not so rare, but each and every one is rare enough that some pediatricians and other clinicians may never have seen a number of these conditions. We hope to kind of get as many of them out in the forefront and just kind of make things more recognizable. Next slide. So when we're thinking about a diagnostic evaluation, for me, it's as a kind of wearing a neurologist or geneticist hat. For others, maybe a little bit different, but generally our kind of central dogma is more or less the same. Being that, you know, we see a child and we ask a lot of questions about their medical history, their family history, do a careful general and neurological exam. And then we try to think, okay, what are the tools that I have that could help me get to a diagnosis? And sometimes that's imaging, sometimes that's blood and urine tests, sometimes that's specific genetic tests, et cetera, et cetera. It all kind of sounds more or less straightforward. But as we all know, it actually can be much more complicated than that. Next slide. And what I have absolutely seen as kind of somewhat of a diagnostician in this space is that along this journey, there are so many obstacles. Some of them are faced by clinicians, some of them are faced by families, and some of them by both. Examples of the kind of things that can make getting a prompt diagnosis more challenging are things like atypical or subtle symptoms. So things that don't really seem like, you know, they're not screaming leukodystrophy or kind of just putzing along, or maybe they're not so subtle and they just weren't recognized because the provider who saw a child or an adult just has never seen these kind of symptoms before and just isn't too sure. Or just, you know, something was completely missed. That can happen too. Of course, another thing that's a really big issue in the rare disease space in general, but also in medicine in general, is things like parts of our diagnostic workup not being covered, whether it's imaging, specific tests, and especially as a huge problem for more broad genomic sequencing. A lot of times it's only partially covered, not covered at all, and that could lead to some big gaps. The cost in general can be an issue. And sometimes it's access in general, just not having, you know, a care team that has the kind of support where they can reach out and ask questions of experts in different areas, or kind of, you know, phone a friend. And so I actually think probably the biggest hurdle that I see, or maybe biggest boulder, if you will, is really this lack of expertise. And part of why working with Hunter's Hope has been really great. And I love these efforts to really involving experts in the clinical care and the diagnostic workup of children, rather than solely focusing on treatments and you know, a cure, which of course is so important too. But I also think it's super important that at every step of the way, even from the very beginning, where there are new symptoms that we're trying to find a diagnosis for, that expertise can be so important, even if it's just somebody reaching out to ask a question, like, hey, does this seem like a leukodystrophy? It's so important. And I think the lack of access to that sort of expertise is often the reason why things can be delayed. Next slide. So just to quickly show a couple of examples of how these sorts of things can be more tricky than it seems, and a couple of case examples that we used in our manuscript. Here, there are just two examples of real cases that came our way. Sometimes, having seen actually multiple specialists before they got to us, we kind of end up being second and third opinion clinics that where diagnoses were missed. And so this is a 27 or 26-month-old who ultimately was diagnosed with infantile MLD, and prior imaging had been done and read as normal, unfortunately, which kind of totally derailed the workup in another direction. Next slide. And this is a 7-year-old who was undergoing surveillance imaging for X-linked ALD, and a lesion was also missed by those doing the surveillance. And this lesion, unfortunately, progressed quite substantially by the time he was imaged again. Next slide. So, you know, we know that these things aren't easy. And actually, all of us, even those of us who would consider ourselves experts in the field of leukodystrophy, we will always, you know, miss things or not know things, and things will be new to us. So we're often phoning friends ourselves. But what we were hoping is that those who we don't expect to have a ton of expertise, let's say in, you know, discerning white matter lesions in an 18-month-old, or in determining how urgent an MRI is, whether an MRI should be repeated, or what testing should be sent. We were hoping we could just demonstrate a couple of ways that children with leukodystrophies have presented, kind of in the realm of first-line clinical care, and then highlight some areas where we felt things could kind of should alert providers towards a sense of urgency. So the first one of the cases, and I shorten these all a lot, of course, so to read more details, you can check out our article. But in short, the first case is a case of Krabbe disease, where we really wanted to highlight this early extreme irritability, you know, often outside of the realm of what we would typically call colic, and also just somewhat more unrelenting. In this case, there was irritability and trouble feeding that really continued and progressed despite typical pediatric interventions, but ultimately was a physical therapist who really noticed the abnormal exam findings that then led to a referral to a neurologist and imaging. And so that kind of course probably took quite a bit longer than it needed to. Next slide. And this is a case of metachromatic leukodystrophy, or MLD. And this is another one where I think this can often be a problem, where this child at 20 months was not yet walking independently, which is a really big red flag, even before 20 months, right? And so this, I guess, timeline should start a little bit earlier, but at 20 months, this child wasn't yet walking. And things progressed over the next 6 months, where there was more pronounced trouble with walking and ataxia. And there was also dysarthric speech. There was a big focus at that time on the walking and concern for peripheral neuropathy, which was, you know, probably also present. So there was some workup done there, and it wasn't for another 6 months until an MRI was done, demonstrating extensive white matter lesions. And ultimately, this child was diagnosed with MLD. Next slide. And then lastly, this is a third case that we had highlighted. There's several more in our report. Was a 7-year-old who was having some new difficulty. And I like to highlight that term because I think it's really important to think about, a child who's otherwise been doing relatively, well in school or nothing's really notable. And then suddenly there's a really big change that should certainly raise our alarm bells. And this child was having some new difficulty with attention, and it wasn't clear if that was because he wasn't really hearing or seeing well, if it was something else. Did not have a prior diagnosis of any kind of learning trouble. And then as time went on, began bumping into walls and not really seeming to respond to his name. So there was concern about hearing, and it was an ophthalmologist actually who ordered a CT scan that was very concerning to them. And then ultimately, this child ended up getting an urgent MRI, and there were, again, extensive lesions. This is a symptomatic XALD case. Next slide. So I think presenting the 3 cases in this manner, unfortunately, makes it kind of feel a little bit doom and gloomy, but it's really not the intention because, of course, hindsight is always 20/20. And we're a group of providers who often who focuses on these conditions, and we're looking for it. But I did want to go back to this kind of idea of this diagnostic evaluation and workup, and this is actually a part of the article that we had put together as well, because I actually do think it works. I think the issue a lot of times is just recognition and expertise, and I probably say this way too much, but this idea of calling a friend, because even working in this space, I'm calling a friend every single day. There's just no way to do this in a vacuum. It really requires, the whole village of us working together to get people diagnosed as quickly as possible. And so, I think the medical history, family history, careful exam, including a careful neurological exam, so that early neurological referral can be very helpful. And then knowing which tests to do and how urgent they should be, it works, but it is important to know how urgent it is. And to be able to pick up on those subtle things that say, gosh, this child needs an MRI, and not in 2 months when the next anesthesia appointment is available, but now. And that's same with knowing, okay, our genetic testing was denied, but I can do this other test first, and I'm going to apply for, XYZ funding, or I'm going to get this free panel that I just heard about earlier by the trivia group. It's just getting that input from people who do know these disorders, I think, is so important. And we can keep trying to educate people as much as possible about how to pick up of things, which is great, but we're still going to need to phone a friend too. So what I also really liked about putting this together with the LCN diagnosis group is we were able to kind of highlight, hey, there are people working on this. These are these LCN sites and things like that, which I'm hoping over time will be helpful. Next slide. It's part of this manuscript as well. We tried to list, of course, this can in no way be exhaustive, and I shortened it a lot here to fit onto a slide, but we just wanted people, I don't know how many people listening today remember things like this, but when you're studying for tests, you would kind of have these buzzwords that would just match with each other, right? And so, for example, I really hope that we can get people to hear adrenal insufficiency or be concerned about adrenal insufficiency in a clinic and immediately think in their head, oh, could be XALD, or I'm sure it's not that, and those are the kind of things that we want people to be thinking about. Other examples being this extreme irritability picture in a young infant, often initially thought possibly to be more related to feeding in general or colic, which is totally appropriate at first to consider that, as long as there aren't other neurologic abnormalities. But remembering that disorders like Aicardi-Gutierrez and Krabbe can have this extreme irritability when things go kind of beyond what we're used to in a typically developing child. And the other thing to think about, especially in leukodystrophies, is, and I think this is something that's very confusing to us as providers, especially if you're not seeing these children and adults often, is that there can be very different presentations. So both Alexander disease and MLD, but many others as well, have this example of this, rapidly progressive early onset form, maybe a little bit later onset form, juvenile form, adult form, and often the kind of most pronounced or earliest symptom can be a little bit different. An example being Alexander disease, in which maybe a first-time febrile seizure in a child with macrocephaly might be a presenting symptom, while as an adult, more things like trouble with swallowing or new dysarthria or other bulbar symptoms might be a presenting symptom. And so things can be really different, and those are the kind of things that we wanted to highlight. Next slide. Another thing that I wanted to highlight, which we didn't get too much into in this manuscript, just because we weren't focusing so much on the testing, we were focusing more on getting awareness about, but I like that there was some discussion of this earlier, even in today's talks, that one thing that makes me so sad in clinic is when I see that there was a child where, I read their record and I could see someone was definitely thinking of the right thing, right? They were worried about a leukodystrophy, but no testing was done because of whatever reason. Maybe they didn't know how to ask for insurance authorization, or assumed it would be denied and didn't even try, or it did get denied once, twice, or three times. And now, we are months to years later and we don't have a diagnosis. And that's so disheartening, especially when everything else went right. And so I do like to always remind people, call your friendly genetic counselor, look online. There are a number of sponsored panels often. There are also often a lot of ways to get more broad genomic sequencing done, which is often needed in the diagnosis of leukodystrophies at no cost. Sometimes it requires an application by the provider, and things like that, but there are possibilities, and usually people working locally with you will have ideas about whether there's other avenues for this too, because sometimes there are local funds, for example, or a way to work with the insurance differently that maybe you don't know about. So just a reminder for people not to let this be a barrier, because it's such a bummer when we get everything else right and then we just get stuck here. And there's so many groups, even research groups, that are able to help us get to the finish line there. The GLIA consortium with the primary site at CHOP is a perfect example of that, where they will, enroll children who do not yet have a diagnosis, but have evidence of a leukodystrophy or leukoencephalopathy on MRI and help with the diagnostic piece. Next step. And then lastly, within this manuscript, this is probably a little bit out of date now, because this was an image that we put in there probably in 2020 by the time it was published in 2021. So this may have changed somewhat, but it was great that we were able to highlight some of the LCN certified or candidate or affiliate centers at the time, but mostly really just wanted to make the point to people that, even if you are, let's say, in Montana and you don't have a local leukodystrophy expert that you're used to reaching out to for help, but that doesn't mean that you don't have people to reach out to help. And as everybody who's been involved in any of the work that Hunter's Hope does knows, all of us are so passionate about getting very fast diagnoses and getting people to a treatment quickly, that we will absolutely answer questions from all over the place. And so really want people to realize that help is out there. Next slide. So ultimately, of course, our hope is that after this long, arduous journey, this is Odysseus after his many years long odyssey, being reunited with Penelope, which, of course, is where this idea of this odyssey probably comes from. However, I always find this a little bit strange, this diagnostic odyssey term, because to me, the diagnostic part should be so short. We should see a child, we should do the evaluation, and we should get to a diagnosis. And then it is when the odyssey starts, because it's not until we have that diagnosis that we even know, if there are treatments available, or that we are eligible for clinical trials. And there is just so much that happens after that diagnosis that, to me, that's really the journey that we're on together. And I really hope that we can continue to shorten this diagnostic part more and more. Next slide. So, overall, I think our main takeaway points, or I guess what we hoped to help by putting together this review that I've been talking about was just to make sure that people understand the urgency here, because delays in diagnosis can absolutely impact outcomes and access to treatment. As we all know, existing treatments and treatments kind of in the pipeline are usually most successful in either asymptomatic or children or adults, or those with really early signs and symptoms. And so it's so important, even more so than it ever has been, for us to get these diagnoses quickly. The family and medical history, of course, are super important, but sometimes you just need to have that high index of suspicion. And so it's always important to ask if you find something you're unfamiliar with. And I always really like to stress that these persistent neurological exam findings, they really should be setting off these major red alarm, like alarm bells or red flags, because it's always a little bit surprising when there's been a persistent abnormality on a neurological exam, plus another kind of symptom that seems more like it could masquerade as a normal pediatric symptom. But that neurologic finding or the abnormal exam is not normal and needs to be worked up really quickly. And there's a lot of people who can help you determine that urgency or feel more comfortable about doing things urgently. And then I think click through one more time. So I guess making lots of points about the urgency, but I say this way too often, but the call a friend thing to me is just so important for all of us, but especially for anybody who feels, that they're not really comfortable or not sure. Seeing a child in clinic for the first time and you get an abnormal MRI back and you think, gosh, where do I go from here? I think this calling a friend point is probably, if there's anything to remember from anyone who reads this article or who hears this talk, I think is the most important piece. And then lastly, I really hope that over time we can stop letting limited access to diagnostics lengthen the time to diagnosis, because, I still get things like chromosomal microarrays denied on a regular basis in 2022, which just makes absolutely no sense. And so I also hope we can continue to advocate for diagnostic testing to be more accessible, so it does not unnecessarily lengthen these times to diagnosis. Next slide. So I couldn't put everybody who was on the LCN diagnosis team onto here. So I just want to say thank you to our LCN diagnostic working group, who really hasn't been able to spend much time together after the pandemic and everything else, all of what is happening in life. But thank you so much for working on this together. And then I also just wanted to highlight the rest of our team at Stanford, seeing children with leukodystrophies, Dr. Keith Van Heron and our NP Nicole Corwin, our genetic counselor Lauren, and Hisham, who is one of our Babush, who's one of our neuroradiologists who works really closely with us. And then we actually have two new team members who both just graduated from fellowships, Becky Levy and Isha Shrivastava, and our two research coordinators, Christina and Erica. And so thank you. That's